Please, Jane, can you start?
Hi, hello, and welcome everyone. My name is Jamie Garcia. I'm a social scientist at the University of Edinburgh, and I'll be chairing today's event. Before we begin, just to let you know that the event will be translated into English and French, and the link to access the translation is posted on the chat. We will also be using the Q&A function, so if you have any questions for the speakers, please put them on the Q&A function at the bottom of your screens, and we will be able to see them better that way. So today's roundtable is titled "What Does Ending AIDS Mean for Africa?" And this idea started through a conversation that I had with colleagues at the Society for AIDS in Africa, because ending AIDS has become one of the most powerful organizing frameworks in global health, and it has shaped, for the past decade, responses to the virus across the world. It has mobilized resources, aligned actors, and fostered optimism. But it has also drawn criticism for its attention towards biomedical targets and the expense of structural, social, and community-led responses. As we move towards a global AIDS strategy for 2026 to 2030, we need to ask, what does ending AIDS mean in the African context? Whose epidemic is being ended and whose is not? How can new technologies overcome persistent inequalities? And amidst shifting funding and political priorities, is the ambition of ending AIDS sustainable? This is the first of four roundtable series. We will be hosting the second one during the International AIDS Society Conference in Rio in July. And these roundtables are hosted by the Society for AIDS in Africa alongside the Center for Biomedicine, Self and Society at the Asher Institute, University of Edinburgh. We have an amazing lineup of speakers today, and we will start with opening remarks from Dr. Nchabi Kwambi, who's the Society for AIDS in Africa president.
Thank you very much indeed, moderator. What does ending AIDS mean for Africa? Distinguished colleagues, stakeholders, partners in health, researchers, activists, civil society, academicians, and Society for AIDS in Africa members. It is a privilege to open this important conversation on what ending AIDS means for Africa. For more than 4 decades, HIV and AIDS have shaped our continent's public health landscape in profound ways. They have tested our systems, challenged our resilience, and demanded unprecedented global cooperation. But they have also driven innovation, strengthened community-based care, and transformed how we design and deliver health services. Today, we meet at a pivotal moment. Africa stands at a point where ending AIDS as a public health threat by 2030 is no longer only an aspiration. It is a measurable global commitment reflected in both the African Union frameworks and the United Nations Sustainable Development Goals, particularly SDG 3.3. These commitments remind us that ending AIDS is not only a health target, but a development imperative rooted in equity, dignity, and shared responsibility. Through the African Union's collective health agenda, including the Abuja Declaration and subsequent continental strategies on HIV, TB, and malaria, we have consistently reaffirmed that health is not a privilege, but a right. The United Nations has echoed this through global commitments that call for ending AIDS as a public health threat by 2030. And yet, as we move closer to this goal, we are also entering a more complex phase of the response. Ending AIDS is not only about reducing infections or expanding treatment coverage. It is about what comes after, It's about sustainability, systems, and sovereignty. As we speak about transitioning beyond AIDS as a public health threat, we must also ask how these systems are sustained, strengthened, and locally owned. A critical part of this future lies in innovation and production. Africa cannot remain dependent on external supply chains for essential health commodities. The conversation must therefore include not only access, but production capacity, including the establishment of manufacturing ecosystems on the continent for long-acting prevention tools such as injectable PrEP, vaccines, and next-generation therapeutics. Local manufacturing is not simply an industrial goal. It is a public health necessity. It determines whether prevention tools reach communities consistently, equitably, and at scale. At the same time, we must acknowledge the reality that countries across Africa are not operating under uniform conditions. This reality does not diminish the commitment to ending AIDS. Rather, it highlights the importance of flexible, resilient financing and sustained global solidarity. Health systems cannot be expected to advance towards ambitious targets without recognizing the pressures they are operating under. It also raises an important question for the global community. How do we ensure that progress toward ending AIDS remains inclusive, even in contexts where health systems are under extreme strain? As we reflect on the path to 2030, we must be honest about both progress and fragility. We have made significant advances in treatment, prevention, and community-led responses. Yet, inequalities persist, and new infections continue to occur, particularly among vulnerable populations. This means that the next phase of the HIV response must be defined not only by ambition, but by realism, not only by targets, but by transformation. Ending AIDS in Africa will require more than medical success. It will require sustained investment, regional manufacturing capacity, stronger health systems, and above all, African leadership in defining what success looks like in our own context. Thus, I look forward to the insights, dialogue, and ideas that will emerge from this important exchange. I would like to thank you all, Sir President. Thank you. Over to you, moderator.
Thank you so much for those inspiring words. As you've rightly said, we've made lots of advances, but inequalities and the need for sovereign capacity to manufacture and respond, and the strengthening of health systems is essential. So we now move to our first speaker, who's Rosemary Museminali. She is a distinguished Rwandan diplomat and politician and has played a significant role in advancing Rwanda's international relations and development agenda. She is currently serving as director of the Multilateral Systems Office at UNAIDS and also as the UNAIDS representative to the African Union and the United Nations Economic Commission for Africa. So we are incredibly grateful that she's found the time to be with us here today. Rosemary, the floor is yours.
Thank you. Trying to unmute.
You're unmuted already.
Okay, good. Thank you, Jaime, for the floor. And thanks to Dr. Kamwe, who we've worked before. And it's wonderful to see many familiar faces that I've worked with and I will be working with again, as you correctly said. I'm moving to the African Union and the ECA, but also as a country director to Ethiopia for UNAIDS. So I really look forward to continuing working with all of you. Thank you, AIDS Society for AIDS in Africa and the University of Edinburgh for convening this very important conversation. I will agree with Dr. Kamwe on very many aspects of what he just told us. I feel that the question before us, how we define the end of AIDS, is really both timely and profound. Especially this week, we've just come back from the high-level meeting on AIDS, and I think the many issues we'll be discussing today are carrying on from there. Today, I think we can no longer find it enough to say that AIDS is not over. We really need to interrogate the more fundamental question: what conditions must exist before Africa and the world can legitimately declare the end of AIDS as a public health threat? I think Dr. Kamwe touched quite a number of those. Our discussion, like in the recent high-level meeting negotiations in New York, provides an opportunity to shift the conversation from charity to structural justice. I would suggest that the end of AIDS should be defined across three interconnected dimensions. One, epidemiological success; two, social justice; and three, structural equity. We have made extraordinary progress in the first. We continue to strive on the second. The third, ensuring that every region has the capacity to produce, innovate, and respond, may well define the legacy of the next generation of the HIV response. For much of the past 4 decades, success has been measured by mainly epidemiological terms: reducing new infections, preventing AIDS-related deaths, expanding treatment and access, and achieving virus suppression. These remain essential measures for progress, but in 2026, they are no longer sufficient. The end of AIDS is not only about controlling a virus, it is also about the kind of global health system that we leave behind. This is really a moment to reflect. We meet at this very important moment. Member states have recently concluded negotiations on the United Nations high-level meeting on political declaration, which was adopted by 146 countries. The negotiations, however, demonstrated remarkable global consensus on our shared ambition to end AIDS as a public health threat. But at the same time, they revealed differentiating perspectives on how that ambition should be raised. One important area of discussion centered on technology transfer, local and regional manufacturing, and the conditions under which scientific knowledge should be shared to expand production capacity. The Africa group, or in the discussions or in the negotiations, proposed language reflecting its long-standing aspiration to strengthen regional production on medicines, diagnostics, and other essential health technologies, which many countries shared. While many countries shared this objective of improving access, they differed on many of the policy mechanisms needed to achieve this goal. It was a clear divide between the developed world and the developing world. I do not raise this to revisit the negotiations. Rather, I believe they illuminate one of the defining questions of the next chapter of the HIV response. Ending AIDS will mean reducing structural inequalities that continue to shape access to life-saving technologies. We need to move from equity of access to equity of capability. The global HIV response has been one of humanity's greatest public health achievements, and Dr. Kamwe enumerated these. Millions of lives have been saved because governments, scientists, civil society, affected communities, industry, and other partners work together. As we look ahead, we need to move from equity of access again to equity of capability. There is another dimension that must remain central to how we define the end of AIDS. That's the area of human rights. The HIV response has taught us that epidemics are not ended by medicines alone. They are ended when people can access prevention, testing, and treatment without fear of stigma, without discrimination, without criminalization or exclusion. Human rights are not an optional add-on to the HIV response. They are one of its greatest achievements. If key populations, women and girls, adolescents, young women, and other vulnerable communities continue to face legal or social barriers to services, then we cannot truly say that AIDS has ended. Ending AIDS will also require sustainable financing. As donor priorities evolve and development assistance becomes increasingly strained, greater domestic investment is essential. At the same time, international solidarity remains indispensable, particularly for low-income countries and for investments in research, in innovation, global public goods, and pandemic preparedness. Today, the question is no longer simply whether effective medicines exist. The question is whether every region has the capability to produce, to adapt, to deliver those innovations whenever it's necessary. It's no longer only an issue of access, it is increasingly an issue of capability. From an African perspective, I feel sustainable access ultimately depends on sustainable capacity. We learned lessons from COVID-19. The world demonstrated extraordinary scientific innovation, yet it also exposed significant disparities. Some regions could access vaccines while others could not. Diagnostics, therapeutics were available to some countries while others we were lacking. Those experiences prompted many countries to recognize the importance of diversified manufacturing, stronger regional capacity and chains, and greater resilience. These are not uniquely African priorities. They are increasingly recognized global priorities. The HIV response now has an opportunity to build on this. Technology transfer is very, very important, and we need to look at it as a partnership. And why I feel this matters, it will define the end of AIDS, not solely through epidemiological indicators, but it will look at the whole picture holistically. Can we truly say that the epidemic has ended? Or are we trying to postpone future vulnerabilities if we don't address those issues? I think there is a shared global interest, and this is where we need to start working strongly to articulate. Strengthening manufacturing in Africa is not only an African interest, it's a global public good. It contributes to global resilience by diversifying production and strengthening global supply chains, improving quality of assurance through stronger regional and regulatory systems, and it enriches scientific collaboration by enabling more institutions and regions to participate in this. It is in concluding, I really want to again say that we need to redefine global solidarity. Perhaps the question is no longer whether we can end AIDS. Science tells us that we can. The more important question is how we choose to end it. Will we define success only by reduction in infections and mortality, or will we define success by whether we have built more equitable, resilient, and collaborative health systems? The recent political declaration again reminds us that these conversations will continue to evolve. And therefore, perhaps as we define this question, we need to continue showing that we need to share knowledge, we need to strengthen partnerships, and so forth. So we will need to redefine how this global solidarity that we are all talking about means, what it means in the 21st century. So thank you very much.
Thank you, Rosemary. Fantastic, fantastic points. As a social scientist, I find your point that structural equity and better health systems may be, well, the legacy of HIV activism incredibly timely, and also what it means to have more global solidarity and more distributed capacity in a world that is increasingly entrenching back against human rights. So very challenging times as well. We now move to our third speaker, who is one second, Dr. Benjamin Udalbai. And Dr. Benjamin is a seasoned global health leader, has over 24 years of experience across Africa, as well as being a medical doctor and a public health expert. Since October 2022, he has served as the head of the Interim Secretariat of the African Medicines Agency, following his tenure as head of the Division of Policy, Health Diplomacy, and Communication at the Africa CDC, and also currently serving as a board member of the Society for AIDS in Africa. Dr. Benjamin, the floor is yours.
No, thank you very much, Jen. And just a point of correction, currently I am the director at Interim at Africa CDC. You know, I am in charge of external relations and strategic engagement. So that is my current thing. Thank you so much. And let me recognize also the presence of my fellow panelists and everyone. Rosemary, happy to see you again online. Minister Kamui, Luke, everybody. I'm really happy to see you all. So having said that, you know, it is extremely difficult to come to speak after, you know, Dr. Kamui and Rosemary, but let me try to say a few words. So when we speak about ending AIDS in Africa, we are really speaking about this, the strength of our public health systems. It is not only a question of how many people are on treatment today, but whether our systems are robust enough to sustain epidemic control over decades and to manage HIV as a chronic condition within primary health care. That is one. So this agenda sits really squarely within the African Union's broader vision of health security and universal health coverage. The same investments that allow us to control HIV, surveillance, laboratories, supply chain, community systems are the foundations we need for other epidemic and future health emergencies. Now, in terms of epidemic control, where do we stand today? You know, we have seen remarkable progress. Many African Union member states have expanded HIV testing, treatment, and virus suppression. And some are close, very close to, or have reached the 90 targets, 95 targets. But progress is uneven. You know, Western and Central Africa, children, adolescents, and key populations continue to lag, and the inequality in access remain a major risk to sustain control. To maintain epidemic control, we must do three things at once, right? So first, reach and sustain high level of diagnostics, treatment, and virus suppression in all demographics and geographies. Second, revitalize prevention, PrEP, condoms, harm reduction, combination prevention while tackling gender inequality, stigma, and criminalization that keep people away from services. Third, protect HIV services from shocks by embedding them in resilient primary health care rather than in isolated vertical projects. Now, for us, you know, public health systems remain the backbone. So over the past 2 decades, the HIV response has helped build an infrastructure of laboratories, surveillance systems, data platforms, community health workers, and civil society networks across the continent. Our challenge now is to combine these assets into a coherent public health system instead of collection of parallel programs. That means integrated platforms where HIV, TB, maternal health and maternal and child health, immunization and non-communicable diseases share laboratories, logistics, and data systems. It means reliable supply chain and increasingly African manufacturing of diagnostics, medicines, and other health products to reduce dependence and improve security of supply. And it means digital tools and data governance that allow us to see in real time who is being reached, who is being left behind, and where we must adjust our response. Now, let me just say a few words about the role of Africa CDC. Within the AU architecture, Africa CDC is the union specialized public health agency. Its mandate is to support member states to build and connect the capacities that make epidemic control possible across HIV and other threats. Africa CDC does this in several ways. It develops and disseminates norms and technical guidance on surveillance, laboratory networks, public health workforce, and emergency preparedness, all of which are directly underpinned by HIV services. It coordinates continental health intelligence and early warning systems, helping member states track epidemic trends and respond rapidly to emerging risks. It supports national public health institutes so that capacities built during donor-funded projects become institutional, sustainable functions of the state. Now, when we try to link epidemic control to health security and financing, I just want to say a few words about that one. Epidemic control for HIV is inseparable from broader health security. The same systems that keep viral loads suppressed and prevent new infection are the ones that detect and respond to outbreak of Ebola, influenza, cholera, or future unknown threats like, the so-called disease X. Through Africa CDC, the African Union promotes integrated surveillance, multi-disease laboratory networks, and regional mechanisms that for joint preparedness and mutual assistance. But this system cannot rely indefinitely on external funding. Domestic financing must progressively carry core public health functions, primary healthcare, laboratories, surveillance, workforce. The AU frameworks already call on member states to increase domestic health investment and to embed HIV within broader health financing reforms. Africa CDC, working with the African Union Commission and partners, helps countries to use resources more efficiently, integrate platforms, and leverage pool procurement and regional production to reduce costs. I will conclude by saying that if we succeed, ending AIDS in Africa will not be one-off declaration. It will mean that our public health systems can keep HIV under long-term control, protect the most vulnerable, and adapt as new tools and challenges emerge. We have a continental platform to turn vertical HIV gains into durable public goods. Strong systems, better preparedness, and greater health security for our people. Our task now is to align political leadership, domestic investment, and technical solidarity so that ending AIDS become not only a global promise, but a distinctly African achievement. Thank you.
Thank you so much. It was great to have your perspective, particularly around how do we embed HIV responses within a resilient primary care, how that can protect us from shocks, but also acknowledging that HIV response has helped to build a lot of the infrastructure that we now consider essential, like civil society and community organizations. I will pick your brains out during the Q&A about political leadership as well as those of the other speakers, but we now move to our fourth speaker, who is Florence. Florence Riako Anam is a Kenyan global health advocate and a thought leader with more than a decade of experience advancing HIV and sexual and reproductive health and rights. She is currently co-executive director of the Global Network of People Living with HIV, GMP+, where she champions efforts to ensure that global policies and research translate into meaningful improvements in the lives of people living with and affected with HIV. So without further ado, the floor is yours.
It's an honor to be here. Thank you so much, Luke, and thank you to SAA and the University of Edinburgh for organizing this series of talks about ending what it will take to end AIDS in Africa. So my task today is to talk about community leadership, human rights, and meaningful involvement of people living with HIV, or as we like to call it at GNP+, GPA, the greater involvement of people living with HIV. I would just like to say and start from the fact that community always knows what is best for community before everything is institutionalized in little groups. People living with HIV met, people who are highly impacted by HIV continue to meet, people who are excluded, key populations, young people who continue to face barriers will meet in their own little ways and groupings of safety to engage in their own way, how to better get services, to stay alive, to keep themselves away from acquiring HIV, and for those living with HIV to support each other so that we all stay undetectable. For me, that is the foundation of community leadership. We have just come this week from the United Nations General Assembly and adopted the new political declaration on HIV and AIDS entitled United to End AIDS by 2030. Dr. Rosemary is here and she will say to you that for those of us who are in New York, this was such a big achievement in the political environment we are in now. It was a demonstration that within HIV, yet again, multilateralism is respectful of the joint ambition to end AIDS as a public health threat by 2030. But also in this ambition is the fact that we are all working towards HIV epidemic control. This landmark declaration affirmed the critical role of community leadership and the meaningful involvement of people living with HIV, guided by the GPA principle, together with the human rights as foundational to the success of the global HIV response. It underscored that community must remain central to implementation, governance, and accountability in the years ahead. But we are doing it even now. Community leadership extends well beyond service delivery, and we are good at task sharing and powering differentiated service delivery through service delivery. I will not belabor on that today. Our leadership encompasses the full spectrum of governance and advocacy work by networks of people living with HIV, key populations, community-led organizations, from community-led research to monitoring and data generation, to supporting in resource mobilization. We are front and center whenever there's a replenishment of the Global Fund. There's all these community members that are working with all partners and our governments in resource mobilizing platforms that will fund HIV responses, to shaping normative guidance at WHO and various other places. Community leadership through secured representation in governance bodies such as the Board of the Global Fund, the Board of the UNAIDS, the Board of UNITAID, and other technical working groups at national, regional, and global levels, continue to show the benefit of working together with all leaders in priority setting, resource planning, and implementation, and our critical role in monitoring and informing where things need to change, what are the bottlenecks, whether people are thriving and not thriving with services, etc. This sustained engagement is indispensable if we are to achieve the 30, 80, 60 targets of the Global AIDS Strategy 2026 to 2031. These targets require that by 2030, community-led organizations deliver 30% of testing and treatment services, 80% of HIV prevention services, delivery for key population and women, and 60% of programs supporting social enablers. Across Africa, where communities have long demonstrated resilience amid high burden and persistent gaps, resourcing and institutionalizing this leadership is really not optional. It's the very foundation upon which ending AIDS will be realized. Equally critical is the advancement of human rights. The People Living with HIV Stigma Index has been the one platform that is community-owned and community-led research instrument that has, for over 15 years, packaged our stories that began initially in support groups and silent conversations of our experiences of shame, vulnerabilities, and pain, and packaged as data that has generated rigorous evidence on the pervasive effects of stigma and discrimination and its barriers to accessing treatment, to staying adherent, and to achieve viral suppression. This evidence has catalyzed reforms in laws, policies, and practices generally. It has taught many how to engage with communities and people living with HIV. It has shifted how healthcare providers engage with people at health provider level, mostly because addressing stigma for people living with HIV ended up addressing stigma within public health. It has led to directly confronting the structural barriers that limit access to services and perpetuate exclusion, particularly for communities that are most marginalized. Currently, and moving ahead, it's providing an essential pathway towards the achievement of the 10-10-10 targets. Also, within the current global AIDS strategies, they are called the social enablers targets, which aim to ensure that by 2031, fewer than 10% of people living with HIV and key populations experience stigma and discrimination, and fewer than 10% experience gender inequalities and gender-based violence, with community-led responses at the center of these efforts. For Africa, the protection of human rights cannot be separated from the ambition of epidemic control. We know that when someone living with HIV is virally suppressed and undetectable, they cannot pass this virus. We have huge numbers of people living with HIV, either not tested, do not know their status, or even if on treatment, do not achieve viral suppression. We also know from data that many people living with HIV have advanced HIV disease. So all of this are not because the medicine is not working, it's because the social structures are making it impossible for people to come and uptake testing, come and uptake prevention, come and uptake treatment, and even if they have their treatment, use it to the point where they get virally suppressed. Health equity is the broader promise of ending AIDS. At the core of all of this lies the JIPA principle, the greater involvement of people living with HIV. This is a signed document, Jaime, and I hope that people can be able to go and look at it, signed by member states in Paris in some years way back. It's the foundation upon which organizations like the Global Network of People Living with HIV, the national networks, the regional ones, across Africa and beyond were established and have been institutionalized within the HIV response. It has transformed meaningful involvement from aspiration into structured participation in program design, implementation, monitoring, evaluation, and as I said earlier, governance. As the HIV response now transitions towards sustainability by integrating HIV services into primary healthcare and universal health coverage frameworks, it is important to secure JIPA firmly within this integration. The role of people living with HIV and affected communities at community and primary healthcare levels remain critical now more than ever to address stigma, to foster community preparedness for the changes happening in the health sector reforms, for treatment literacy as we move ambitiously and excitedly towards innovations of long-acting prevention and treatment, creating demand and advancing advocacy that will be needed for market shaping and market access. And this, I hope, will get us to the point where we all want to achieve viral suppression for all people living with HIV. For Africa, ending AIDS must really mean intentionally placing community leadership, human rights, and meaningful involvement of people living with HIV at the center of everything. How, you may ask? I want to offer three things as I close. One, we have to secure sustainably. Someone challenged me to stop saying we. Governments, donors, leaders, with support from the UN agencies under the leadership of UNAIDS, must ensure that there is secure, sustainable, and equitable financing for community-led responses. Adequate, predictable, directly accessible funding is what will be needed to keep the work we are doing alive. Institutionalize Number 2, meaningful community leadership in governance and decision-making structures. As the health sector reforms are happening, as the shifts towards sustainability are happening, JIPA must be firmly embedded across all levels of the policy development, design, including within primary and healthcare and UHC frameworks. Refer to my comment earlier around institutionalizing JIPA for integration. I think one of the things I would like to offer here as an example that can be strengthened, it's probably not working everywhere equally, but it's already existing and we can strengthen, is the Global Fund Country Coordinating Mechanism, which brings communities with lived experience of HIV, TB, and malaria together with our finance and health government leaders, implementing partners, and other stakeholders to jointly plan, resource, and jointly implement national priorities across these 3 diseases. It could be something that could be emulated and scaled up. Number 3, and finally, strengthen community capacities and enabling environments for integrated rights-based responses. I would like to say this. When I started my work over 20 years ago, I went to, the radio and the community. We used to have those art things in the market and told people I had HIV, how they should do, what they should do not to have HIV, and if they have HIV, what they needed to do. I have grown in the sector because the organizations I've had the opportunity and the honor to work for allowed me the opportunity to be trained, to go back to school. What I'm trying to say is the quality of our advocacy is impacted by the growth of our institutions and the knowledge and capacity given to us through those institutions. So strengthening community capacities really must be investment in building our technical, organizational, and leadership capacities so that we are able to advance human rights. I went around teaching people, what is your human rights? Human rights you have rights and you have obligations, and all these things were taught to me so I could teach it to someone. So building and securing these levels of capacity building as we go ahead will be important. I think as I close, we have the opportunity with this political declaration. It provides renewed political impetus. Our task begins now, which is to translate these commitments into concrete actions for Africa, adequate and predictable funding, and genuine friendships that must be built in Africa for Africa, with communities in the lead, front, and center. I know we can end and we will end AIDS, not as a public health threat, but because we need to keep people alive. Thank you, and back to you.
Thank you, Florence. I really enjoyed how you started saying that community always knows what's best for communities. And the challenges that we now face, which tie in with what other speakers have talked about, how do we ensure that community leadership remains at the center as we integrate the HIV response onto primary care and other responses. We've had a lot of questions in the Q&A, so we may not be able to answer all of them, but I would like to pose the first question from the audience to all 4 speakers, which is what can we do with the idea of ending AIDS, talking about rights, talking about communities, when we are also seeing situations of conflict, situations of climate impact or the impact of climate change in many countries, or in some countries in Africa. How do we hold both things at the same time? How can we talk about those things, and how can we address them in situations of conflict, like the ones that are at the heart of the Ebola outbreak? Do any of you would like to start?
Thank you so much. I have provided some indications in the Q and R there. When in conflict settings, it's extremely difficult to respond to any crisis. But what we need to do, I see mainly 3 ways, is to integrate HIV into humanitarian responses. regardless of the nature of the crisis, there is always a humanitarian response. So we should not forget about, this integration. Two, we need to protect continuity of, treatment and prevention, and the continuum of even services, not only about for HIV, but for currently we are having an Ebola outbreak in Eastern Congo, namely in Ituri, where you have a lot of armed groups in the region. It is a conflict affected area, but the most important thing is to ensure that you continue the continuum of service is extremely important, and you need to have the dialogue even with the different parties in conflict. That is extremely important. Two, of course, when you are coming up with your peace and security, plan or reconstruction or whatever, this should be embedded into the framework that we are putting in place. So just indicative, we can elaborate, but I just want to give the key points, giving the time that we have allocated to this webinar. Thank you.
Okay. Rosemary, Florence, yeah, go for it.
Okay, thank you. I tend to agree with with Benjamin on especially integrating our services, especially in the humanitarian services, in the delivery of humanitarian services, because they say that we need to prepare for war in peace times. I think this is really important that as humanitarian activities, humanitarian policies and strategies are developed, very, very important that we embed the issue of dealing with HIV in there. That's why UNAIDS has been working with the humanitarian agencies, that is WFP, UNHCR, so that their tools, because these are the organizations that operate in conflict areas, so that their tools can be also made in such a way that they can deliver on HIV and ensure that the packages include a delivery on HIV. The second part, I do think, goes back to what Florence has been talking about and really emphasizing the role of communities. Conflict happens within communities. They are the ones who know who needs medication, who is on medication, who needs what services. And therefore, I think empowering communities in such a way that they can be able to continue to deliver, whether they are on the move, whether they are under distress and so forth, I think is very, very important, so that even those policies and strategies that I'm talking about are built with communities in mind. The JIPA principle, that we cannot overemphasize the JIPA principle, and therefore really putting the tools in the hands of the people that are actually at the center, not only of the disease, but also are at the center of where we need to find the people that we want to support. So those two areas, I think, embedding our interventions within even humanitarian interventions, but also ensuring that our communities are entooled. We are talking of strengthening health systems, but the first target that decimates health systems and is the conflict, is the climate change, and so on. So we need to strengthen the kind of structures that are always there, whether strong or weak, but they are there. So I feel that communities. Thank you.
Thank you, Florence. Anything you would like to say?
I think Rosemary has said what I would have said. I just wanted to add that I know GNP Plus is part of the UNAIDS and UNHCR convinced other UN agencies, including WFP and others, around HIV in humanitarian settings to develop the tools that Dr. Rosemary is talking about. But I think just to add on to that, there's planning when there's no conflict or whatever, but then there's the actual experience. And at that moment, frankly, it's the communities that are sitting there and they're the frontline point of contact. So flexibility in funding or supporting the quick emergency funds, I don't think we put a lot of that into context, especially for communities like in West and Central Africa, where we know these are experiences that happen, or like in Southern Africa, where there's always a humanitarian experience in some way, shape, or form. So also for donors to be a bit more innovative in allowing for flexibilities of funding to shift when emergencies happen.
Thank you. You've all three talked about humanitarian response. In your presentations, you've all talked about human rights. I would like to push you a bit further onto that. The three of you have recognized the importance of human rights as a key framework for the response to HIV. But how can we sustain that when there is a global pushback against human rights? A few weeks ago, gay men, Global Black Gay Men Connect published a report that showed that all the memorandums of understanding signed by the US with countries in Africa failed to include any discussion of human rights, of key populations, or any safeguards for equality in delivering those programs. So we're seeing similar sort of conservative waves in Europe and in other areas. What can we learn from the HIV response to face the challenge that are going definitely to come within the next decade in the field of human rights for HIV? It's a sad question, I'm sorry. Maybe Rosemary might want to start.
Well. It's, as you said, it's a very sad question. Again, you needed to be in New York this week to see how strong this is. Those who have been in the high-level meeting, we've never seen so many countries, sadly, on our continent, on the African continent, take the floor to denounce, these very areas that you've just talked about. And therefore, I think it's really, really key that we do not give up. We do not give up. We continue pushing. And we also try to highlight as much as possible using data, using proven scientific knowledge, the fact that if we are investing in only one part of the population and leaving out another, I think we are not fully investing our efforts and ensuring that where there is that issue of human rights, we focus also on the issue of ensuring that there is universal access for everyone. Universal access for everyone. Again, I want to go back to communities. I think that these are our run-to solutions for all of us. And I think as we empower communities, communities will not let their own down. Communities will ensure that in whatever difficult circumstances, they are able to cater for those who really need the needs. So we continue to, one, push the data out, show how these issues affect everyone eventually, but also we empower those communities that are not pushed and swayed by the political issues. Many of the political pronouncements are really playing to the gallery, are playing to the voters. If you speak to many, and I'm sure everybody, Benjamin, Florence, Dr. Kamwe who spoke first, everybody knows that after people have waved their flags and spoken like that, they will come back and protect these people. They will ask their police to continue following up and supporting these people. We've seen that in many countries. So we need to make sure that we are working directly with the people who are affected, with the communities of people who are affected, but also we continuously push out the data so that they cannot avoid this data that they keep getting within their numbers. As they try to eliminate, everybody wants to eliminate and make sure that they are safe of HIV, but sometimes they are playing counter by the pronouncements they make.
Thank you. Florence or Dr. Benjamin?
I think what I will say are a couple of things. For me, I look at the political declaration as an instrument to start this conversation from, because we now have a signed declaration that has chapters on respect of people's human rights, and that's an opportunity to start. Additionally, I think the fundamental principle of human rights is right to health before we go anywhere. And I think with empowering each other at community level to ensuring that we are all accessing our right to health, and then using the evidence and the data that we will continue to bring up for the barriers towards that right to health. If there's a commitment to get 95% of people living with HIV on treatment and virally suppressed, and there are barriers to that, and at the cornerstone of that those barriers with evidence is data that shows violence, structural barriers exist with violence or stigma or punitive laws, then data is there to show what works and what doesn't work. But at the community level, two things must happen. One, we must go forth with so much urgency right now to educate ourselves about what our rights are at different country level, embedded even at, if because we are now doing national and government-owned leadership for HIV, what's within our constitutions, and then document where these barriers exist so that we can use that evidence to push for the change that we need.
Thank you. Dr. Benjamin?
Okay, I will speak in French. Non, c'est une question extrêmement importante quand on parle des gens qui sont marginalisés dans le cadre de la riposte. On ne peut laisser personne derrière, en fait, dans cette lutte. Et je pense que si beaucoup de délégations, par exemple, récemment à New York, ont pris la parole pour aller à contre-courant de ce qui devrait être fait, c'est tout simplement conjoncturel. Conjoncturel parce qu'un pays comme les États-Unis aujourd'hui, nous connaissons le discours public et certains pays veulent plaire à ce que pensent les États-Unis. Donc, c'est une histoire d'alignement. Mais quand on regarde de près ce qui se passe dans les pays respectifs, c'est que c'est vrai qu'il y a des défis, mais certaines populations sont protégées, notamment les hommes ayant des rapports sexuels avec d'autres hommes, etc. Autres, tout ça, ont accès aux services, même si les conditions sont de plus en plus difficiles. Je pense que nous ne devons pas baisser les bras. Nous devons continuer par faire ce travail de plaidoyer parce que si nous parlons de mettre fin au VIH comme problème de santé publique d'ici 2030, cela voudrait dire que nous devons tenir compte de tous les segments de la population. Personne ne doit être ignoré. Et c'est extrêmement important parce que vous avez ces populations clés qui sont des relais, qui ont des relais dans la population générale. Donc, si vous voulez résoudre ce problème-là, il faudrait justement cibler ces populations clés pour réduire la prévalence et ceux qui sont infectés, par exemple, les garder, supprimer, par exemple, la transmission en gardant vraiment la charge virale indétectable, sinon on n'arrivera jamais. On n'arrivera jamais et tout le monde est responsable. Je pense que les politiques en premier, les politiques en premier sont très concernés, même si de manière publique, ils ont un discours, je dirais, plus assaini. Mais c'est une situation qui devrait être, qu'on doit regarder de très près et que nous ne devons pas ignorer. Voilà un peu la contribution que je voudrais apporter. Merci.
Merci. And before we finish, I would like to throw in a last question that's also being sort of asked by Dr. Ratevosian, who's one of the leading experts on global health. And he asks about technology, including AI. I would extend that to other forms of technology that you've also talked upon, including long-acting injectables such as lenacapavir and cabotegravir. Is the focus on developing more technology, more, more treatments and more preventative measures and more data? Is that helping us, or is that a distraction sometimes from the structural and social barriers? Because with COVID, we saw that the development of vaccines very rapidly did not translate into equitable distribution. So is a drive to develop more medications, to develop more data, more tools, helping, or is it sometimes hindering the structural changes that the response needs?
Do you want me to come first?
Yeah, sure.
Well, okay. Lesson number one. Lesson number one is that we cannot stop progress, regardless of the domain, and particularly, when it's come to eliminating a problem as a public health problem, public health threat. We cannot stop progress until we find a cure for HIV. We can't stop, right? So that is extremely important. Yes, translating, we cannot stop progress. And of course, there is a cost for research and development. And most of the pharmaceutical companies who are behind, the new discoveries and etc., need to recover the cost of the R&D. That is extremely important. But also, we should not lose focus, on the fact that when it's come to public health, everybody is concerned, and we need to get access. Yes, you mentioned the case of COVID, especially for Africa. It was extremely difficult when the vaccines were available. The other side there, in West. We waited for so long to get access to the vaccines, and we should not forget, the equity. Equity is extremely important, and the global solidarity. Even so, it is not because of equity or global solidarity we should stop the progress. Those progress should continue. I will not say that it is a distraction. It is not. It is a positive sign if we come up with new tools and discovery of new drugs, etc. It is extremely important. But we should be also able to say, okay, let's transfer the technology. Let's give access to the IPs, and licenses, for the countries in the global south to be able also to manufacture, to develop, so that we can talk about universal access when it's come to public health threat like HIV or any other condition that is threatening the global public health. Thank you.
Thank you. Florence or Rosemary, would you like to add something?
Yeah, I'll just add something to what Benjamin has just said, which is all very pertinent. What I will add is that yes, very important. We cannot stop development. We need to support it actually, but we also need to continue emphasizing the virtue of sharing capabilities. I think at the background of all this is the issue of inequalities. Huge gaps in capabilities. And we need to continue showing how detrimental these huge gaps are. And also at the same time showing how beneficial, the more we keep on narrowing these gaps, the better it is, even for those with capacities. So that we are showing how those who will be getting enrolled onto these technologies are creating future markets for the technologies, are creating future benefits for those who are innovating. So we need to labor to show that. I'm not the best in showing that, but I feel that the capacity of our advancing and reducing these inequalities is to continue to highlight them, but also continue to highlight the virtue of enrolling more people and getting more capabilities even to the innovators and the big scientists. So that the more people you have on your market, the more people you have consuming your technology and using it, the better you are getting and the better the world is getting. So we need to sort of highlight that. It sounds almost naive, but this is where we need to move if we are to make any progress. Again, I will go back to these negotiations we had last week. One of the contentious phrases was sharing technology based on mutual agreed. That is just basically saying you can only use this technology if the owner allows you to use it. And the arguments, which I really, and being in UNAIDS, and I was very anxious to have the political declaration acclaimed and passed, I was hoping that no, Africa maybe should relax a little bit and leave that. But they pushed, and in the end, we were able to have the whole strong point in the political declaration. So I think the issue is not giving up. The issue is creating a critical mass to keep moving this forward. And I think that's how we'll be able to get there. It's not easy because there is a huge, huge disparity. I think you heard last week about Elon Musk and what he's doing and all that. And think of our African countries where we are struggling and what we are doing. Some of it is almost above our head, not almost, but quite above our heads. But I think very important that we continue showing how even when you've gone to the space, you will need to have a safe place to land that does not have disease, you won't land there and then you are decimated by these common issues that affect us all. I think COVID was a very bad thing, but it also showed the world that we need each other. Ebola now, what it's doing right now. Thanks.
Thank you. And I think we still have some questions in the Q&A, but we are running out of time. So I think this is a really nice place to finish with Rosemary's words about even if you get to the moon, you still need a place to land that is free of disease and hopefully full of human rights. I would like to thank, before we finish, the team from the Society for AIDS in Africa, Lucarman Bodia, Gordon Tambro, and Emmanuel Kwatsi, who have been helping to set up and organize today. You will all receive a survey asking for your feedback, and upon completion of that, you will be given access to the recording from today's session, which has also been streamed on YouTube. And finally, we would like to share the notice for the next roundtable, which will happen in hybrid format at the International AIDS Conference in Rio in July, but will also be online, and we have a great set of 3 speakers, Lucille Butler, Aveline Faubank, and Stephen Hile Tashabalala, who will talk about some of the things we've talked today: innovation and access. What role does innovation play? How can we make sure that access is put at the forefront of research and development? Thank you for all of those who joined, and if there are any questions or follow-ups, please feel free to email me at the University of Edinburgh email. Thank you.
Thank you. Thank you very much.
Thank you. Bye-bye.